So let's get through Model 3 and then take a break, right? Take a break? Okay. So Module 3 is not probably a fair amount of slides, but pretty straightforward. Module 3 objectives: identify overarching principles for patient care, describe strategies that for evaluating and addressing the psychosocial medical issues, address issues with special populations, describe strategies for engaging and retaining. I suspect that every one of you here is very, very good at that. But, how do we convey it to the rest of the staff, or to the person who answers the phone, or to the person who is not as adept at treating addiction as you are, and identify effective referral techniques promoting initiation of substance use treatment. So we're going to look at a couple of things here. When you look at, assessing someone, these are the biomedical domains. These are the things that we look at from a physical, if you will, and medical perspective. General health history, mental status, physical assessment, use and patterns of abuse, substance use and abuse, and past treatments. And I see the heads nodding. I think this is all pretty familiar to most people here. The psychosocial domains, I suspect you're much better at this than I am. And these are the demographics. Where are you living? Who are you with? What's your highest grade level? What's your language? What's your spiritual affiliation? Living conditions, who are you with? Violence and suicide risk, transportation, finance, dependent children. See, you guys hit almost every one of those. You looked ahead, didn't you? I know you did. Legal status. Do you have 4 warrants out for your arrest? I mean, you answered yes so quickly because I know we've all seen that, Physical, sensory, and cognitive abilities or disabilities or limitations. And those are all things that we look at. These are conditions, as a rule, and it's a little bit nebulous, but these are conditions that require or may require immediate medical attention. A sudden change in mental status. In other words, someone is up, walking, talking, calling you names, says they don't want to be there, and all of a sudden you can't wake them up. I mean, something's wrong. Increase in anxiety or panic, and that is of a significant degree. I don't know of too many patients that go through detox without having some degree of anxiety. Hallucinations, again, that medical attention could be delivered in the setting that you're in. Doesn't mean that they get shipped out. And remember, we talked about some of the freestanding residentials. They have medical consultation available 24/7. So they'll have protocols like, for instance, Brighton Hospital. There's no physician there at midnight, but there's protocols and there's a physician available by phone. So this could be managed in the setting that you're in, but these are things that would require attention. High body temperature, increase or decrease in blood pressure. Insomnia, that's from the tip. I'd take that out of there because that is such a common concern among most people in detox. The exception is the stimulants where you can't wake them up. They crash. But effectively treating that is important. Abdominal pain, GI bleeding, either end, and changes in responsiveness of the pupils. These are conditions that may require immediate psychiatric attention, suicide risk, and anger. Now, again, with anxiety comes anger. I wouldn't be here if it weren't for that wife or husband of mine. I was minding my own business, and I think the cop's having an affair with my wife because he followed me home after the bar. These are the things that we often see in that detox setting that I know that you're very adept at working with patients who have that. Now, the de-escalation of aggressive behaviors, I think most organizations offer training in that may have to isolate an individual, speak calmly, be supportive. And it's pretty amazing how powerful that is. And, in a treatment center setting, I think all of us got a real good handle on how to do that and why it's important. And physicians, do we have any physicians? No? So, by definition, you don't give any medications, right? I mean, you may give them, but you don't prescribe them. And yet, I suspect that almost every individual in this room is very effective at de-escalating those behaviors, just through support and techniques and counseling and and interaction. And what do you think the tendency of most physicians is? Give them some medicine. Just give them some medicine. So again, we see that it's all of the treatment components intertwine and sometimes may actually work a little bit in opposition. And significant co-occurring mental disorders. Now, it's interesting that the American Society of Addiction Medicine and the American Psychiatric Association both have stated that you should wait, and someone who has chemical dependence and is going through withdrawal and detox, that you should wait 2 to 4 weeks before making a diagnosis of a co-occurring mental disorder. Both of those organizations. And I think that that's pretty good advice. Now, there's some exceptions. Part of this that's critically important is the history. And the history, in the ideal situation, you get supportive history from family or support people. Now, if someone comes in who is 31 years old and is alcoholic and tells me they suffer from severe depression, and I take their history, and their first drink was when they were 19 in college, but they were in a psychiatric hospital 6 to 7 times from the ages of 16 to 19 for depression before they ever had a drink, I might not wait 2 to 4 weeks. So I think it's good. We used to, remember if you remember in the old days, anybody been around since like the 70s, they used to just say, well, you got to be sober 2 years before we'll think about you being depressed or anything. And that didn't work out too well. Because if you did have a co-occurring disorder, you wouldn't make it 2 years. And then the pendulum swung the other way. It was like, well, I know you're drinking and drugging a lot, but it must be because you are bipolar or have a borderline personality disorder, or you have anxiety or social phobia. And that didn't work out too well. So, my opinion again, I think the pendulum's sort of in the middle there, and we realize that it is very difficult in some instances and possible to make a secondary diagnosis in a detox setting. But yet, sometimes we can. I mean, it's probably not too difficult to get a suspicion of coexisting schizophrenia, based on history. And although you may have hallucinations and withdrawal, but you can look at that history and family support, previous hospitalizations. Now, the best advice that I ever heard is from an addiction doctor, Dr. Kirk Brower, and he's an addiction psychiatrist. And so when he was asked this question, like, well, how long do we wait before we consider a secondary diagnosis? Is it 2 years? Is it 2 weeks? And I really liked his answer. And to paraphrase, he said, you wait as long as you can until you can't wait any longer. And I've really used that a lot. Clearly, if you have someone 5 days after straightforward alcohol withdrawal, and they are so depressed that they won't get out of bed, and maybe not overt suicidal ideation, but darn close. I mean, I'm not going to tell someone like that, well, in 9 more days, I can consider treating your depression. So that's the clinical skills that you all have, I'm sure, and that you're able to ascertain, well, doctor, I'm seeing this patient, been coming to 10 days, but I think we need some input from you regarding fill in the blank. So that's what you do as clinicians. Nutritional considerations, and as I said, I think we can go through these slides rather quickly. Nutrition, it's in your handout. They're very important, and I might add probably one of the most overlooked elements. I mean, a relatively good-sized freestanding treatment center might have input from a dietitian, but oftentimes in an outpatient setting, you're not going to have that. So I think it would be reasonable to know that these are important factors to consider, not that we would know how to balance an individual's diet appropriately. The other thing is the dietitians quickly learned in the treatment settings that I was in. They're so used to having like a diabetic. They go, okay, here's your exchanges, and here's what we want you to eat, and 3 of these, and 2 of these, and 1 of these, and 1,200 calories, And that's even hard with a diabetic. But you try telling that to someone, in detox or even in early recovery, I mean, that's the last thing they're going to be thinking about. So the nutritional challenges, not only the challenges themselves, but how we approach them is a big factor and important. Adolescence, oh man. Oh, what a challenge. And we see more and more of that as we see that age drop. Binge drinking is very common among them. And you may see someone present with their alcohol blood levels are going up. Binge drinking is common. Often they take drugs that are not identifiable. What'd you take? I don't know. And they really mean it. They routinely screen. It's important that we routinely screen for illicit drugs. Often non-disclosure of drug use. Probably many of you know when you had a young person, 19, legally an adult, come into treatment, there's mom and dad, right during the interview. What do you think the likelihood is that that young person's going to say to the assessor with mom and dad there that, yes, I'm shooting up heroin? And so, I mean, I see the smiles when we say that. And that's why oftentimes, we make every effort in treatment settings to have the parents there for collaborative information and to give that individual the opportunity to speak without the parents there. And screen for suicide potential, which is an important issue in teens. Parents with dependent children. Now I'm going to ask you all the questions. Who was the mother and children over here? There we go. Pretty straightforward, yet huge problems. Parents, especially mothers, fear for the safety of their children. Some children would experience distress while the parent's in treatment. Ensure children have a safe place to stay, and social services may need to be involved. Toot sweet, very, very early. We talked about how powerful that drive to drink and drug is. If you're addicted, it's one of the most powerful drives there is. Now, what's another powerful drive or instinct, if you will? Parenthood, right? Parenthood. Not just humans, but animals will lay down their lives to protect their young. And so, what I would see so often is someone who was a mother or a father, and they have children at home, and yet they have this addiction. And that dichotomy could be absolutely overwhelming. It goes against every instinct, yet your continued use is in opposition to that parenthood. And one of the most touching and moving reasons for admission that I ever would hear, and I'd hear it frequently, was what caused you to come into treatment? And usually it was a mother who would say, well, I got my 5-year-old ready for kindergarten today. And while I was packing his or her lunch, she said, Mommy, please don't drink today. Mommy, please don't take those pills today. And, precipitated treatment, but the shame is so intense. And that is really where your education of this is a disease. The thing that, again, personal thing that I did, you may do similar things, I suspect you do, but people would come in and for instance, I would hear a lot, well, I got arrested for child endangerment, for being drunk and having my child in the car without a seatbelt on. And you see this pain, and here you are trying to offer hope. And the thing that I would, say, and sometimes it was even more tragic than that, as you can imagine. But I would say, would you have done that if you weren't drunk? And the answer is no. Well, of course not. Okay, we're here to help you begin your treatment for that condition. That hope is critically important early on. And they come in with a lot of baggage. And the problems of both pregnant mothers and parents with children is big time barriers. Domestic violence victims, both men and women can be victims. Increased risk for female drug abusers to be victims. Develop a safety plan when violence is disclosed. What will you do if, let's say it's an outpatient setting. Okay, this, counselors better than physicians. What will you do if this happens again? What are your options? and avoid communications between abused and abuser during detox. Victims may need help with parenting skills, and know local child care resources, and I would add, or lack thereof, because some of those are intense challenges. Considerations for culturally diverse. Patients' detox expectations may vary. Patients' experience and healthcare system may also vary greatly. Patients cannot be defined by their culture or ethnicity. Use open-ended questions to gain understanding. What happened to you what was your experience the last time you were in detox? Open-ended. Important to have bilingual. Bilingual is misspelled, I apologize. Usually it blips up with a red line, and it didn't, so that must be a word also. Bilingual staff, if possible, to avoid language barriers. Metro Detroit, I would suspect Spanish and Arabic are of critical importance depending on the populations that we're serving. Chronic relapsers. Man, that's a tough one. That was me. The relapser may feel hopeless and vulnerable. Acknowledge the progress that was made before the relapse. Reassure that gains from prior progress have not been lost, and reinforce the importance of recovery. Now, what I would often do is, we would see people double-digit admissions just to our facility. And the question that I found most helpful, open-ended too, well, you've been here 11 times. Any thoughts of what you might do different when you leave this time? Because, and the AMS knows, when we see people with multiple treatments, I go, to do the same thing and expect a different outcome is not realistic. And it's amazing. That's pretty non-threatening, And also, if you're confronted with, what are you going to do different? Well, I don't know. I have no idea. Okay, well, when you left last time, did you go to meetings? I don't like them meetings. Did you take any of the medicines for, let's say, alcoholism or other substances? No. They would always say, I go, why not? They would always say, oh, those medicines scare me. And my answer is always the same. Have you looked at your admission picture? You see, that needs to scare you a little more. Did you go to your aftercare? No, I don't have a car. It's 8 miles away. And of course, I always did MAPS, the prescription monitoring program. And in those instances, I go, well, you didn't have any trouble getting the 5 different doctors, some of them at least 30 miles away from your house to get those pills. And so you see, you're hammering through some significant denial, but as a rule, that's pretty non-threatening. Just this, I would always like to, they would tease me on rounds that I was like Columbo. Because I used to love going in there, reading the chart, looking at the family statement, doing a map, getting the old chart, all the information I could get, and then go see the patient. And it was always, so you just drink, right? Oh, just booze. You don't use any other, you don't use Xanax? No. You don't use Adderall? No. You don't use OxyContin? No. I always go, well, now here's the funny thing. I did a MAPS on you. And what's a MAPS? Oh, I'm going to show you, And so, pretty quickly hammer through that. And remember, I think as far as denial, the best analogy that I ever got on people with addictions denial is this. The students, med students, nursing students, social work students, pharmacy students, PA students would rotate through. And you would talk to them, by and large, they don't know anything about addiction. It's getting better, they're there to learn, but they don't know much. And so I always would talk about denial in a couple of days. Remember, that patient is in denial. They don't understand this either. About the second day, a third-year medical student comes up and says, you know what, Dr. M, I think I get it. Now, when a third-year medical student says that to you, you should get nervous, But I said, what? And he looked at me and said, if we were to give all these patients down this detox hallway lie detector tests, they'd all pass. Perfect. I love that analogy because I think they would. Strategies to engage and retain patients, offer hope, we talked about that. Atmosphere with comfort, relaxation, cleanliness, security. Educate them on the withdrawal process. This is what you can expect. We're going to, do this assessment, then I mean, that fear of the unknown, if they've not ever been in a detox setting, it's very frightening. Very frightening, especially if they have an element of physical withdrawal. Utilize support systems, maintain a drug-free environment. Easier said than done, right? Easier said than done. Consider alternative approaches, acupuncture, meditation, healing circle. Where I was before, in the past, every Thursday they have a healing circle. It's like a Native American thing. And they would have a little fire out on the grounds there, and they have all the patients sit around there. And I may not be right, but I'll never lie to you. And so I'm thinking, that's pretty hokey. How can that possibly help? And lo and behold, when I was on call, I noticed that on Thursday nights, when they had that healing circle, I got a lot less calls. I got a lot less calls for AMAs. I got less calls for trouble sleeping, less calls for anxiety. So, use Loeb's laws. If it's helping and it's not hurting, keep doing it. Enhance their motivation that we're going to briefly go over, and foster a therapeutic alliance. Enhancing motivation. Focus on their strengths, show respect, avoid confrontation, provide individualized treatment, avoid using labels. Just this morning on the radio, I was coming in here and listening. I listened to the radio. It's on camera, so I won't tell you what station. They were talking about a professional athlete who was involved in some. And the statement went something like, he's a stupid drunk. He's nothing but drunk and nothing but stupid. It's a label. Now, I don't know. I'm not involved in the care of any individual athlete at the present time. But they may have a substance problem. And as all of you are aware, we're right on the fence. I mean, I don't know if I should go in this treatment or not. And then we hear something like that. That makes the decision for me. See ya, I'm out of here. So how critically important those first approaches and interactions. Use empathy, recognize small steps, in an outpatient setting. So wait a minute, you only used 9 days in the last month. When you started 2 months ago, you used every day. I see the heads nod, you know how to do that. Reflective listening, and raise awareness of discrepancies. I think that is a very effective and a tool that I often use. In two respects. One, with their goals and values. Well, you said you wanted to be a good father, and yet you missed 3 of your son's soccer games because you were at the bar drinking. You see, that's a discrepancy in goals and values. And the other discrepancies we've alluded to a little bit. So you only use alcohol, but your drug screen's got 3 other drugs in it. That's a discrepancy. Or you told me you only drink 2 days a month. You get drunk, but only 2 days a month. But your lab work shows that there's liver irritation. You don't usually see that when you only drink 2 days a month. So using those discrepancies from a perspective of empathy, very powerful tool. Stages of change. Anybody here not know these stages of change? So I think we're all aware of these. When I first saw these, I wasn't terribly impressed. I thought, another thing for me to try and remember. Now I've really come to appreciate the beauty of this, and that without these, my goal is you get someone in that has an intervention and you want to get them to recovery and maintenance. And you get frustrated when there's a little problem doing that. And this is really helpful for me because, whether they're pre-contemplation or contemplation, I don't think that's as important, but what's the next level we can get them to? That may be all you're going to do at that particular treatment exchange. Because most studies show most individuals who go to treatment and eventually get sober go to multiple treatments. So moving them along that transition. Therapeutic alliance, supportive and empathetic, refer when you can't engage them, rapport, confidentiality, cognizant of the challenges for the patient. Consistent, trustworthy, reliable, calm, cool, confident, and humble. Sound like the Boy Scout creed, if anyone remembers that, but I think those are very important attributes. Be able to set limits without a power struggle, be aware of their progress, encourage self-expression. Barriers to referral after detox. This is a toughie. They think they're cured. Why, I'm detox now. They may feel they no longer need help after detox. As we talked about, insurance may only provide partial or limited coverage. The paperwork for the patient or for you for insurance can be overwhelming, and patients may struggle with the insurance system. Now, their rehab needs. What do you look at when you assess what type of rehab they might need? Psychosocial, special needs that limit access to rehab, limitations or conditions may limit suitable treatment settings. Someone in a wheelchair would need wheelchair accessible. Someone who with a hearing problem would need to have a setting specializes in that. Who was from Salvation Army? The one in Monroe? Yeah, you guys still have that, correct? Salvation Army in Monroe is the only treatment organization I know of that is able to accommodate people with hearing problems. Gender-specific, dependent children, and the support systems. And these are the areas that you would consider when determining what's the next level of care. And I think we have gone over all of these previously. So those are in your handout as a little crib sheet. Treatment settings: inpatient, residential, therapeutic communities, transitional or halfway houses. And there's some overlap there, like halfway house, three-quarter house. I always look for a 3/5 house, something in between. I don't need all that structure. It's a terminology on degree of, when you were a patient, you said restrictions. When you're a clinician, you say support. Same thing. The PHP and day programs: intensive outpatient, traditional outpatient, recovery, maintenance activities. Now, research has shown that patients are more likely, this is likely to be on the question, you won't get these questions, but if you see this online, this is going to be one of the questions, okay? Wink, wink. Patients are more likely to initiate treatment if they believe that they're going to be helped, that just makes sense, are employed, not too much we can do about that, but it's a predictor of an outcome, motivated beyond pre-contemplation. I mean, you got okay, I think I don't want to keep using the way I am now. It's contemplation. They're thinking about it. Have family and social support. And the last one, have, and that may show up on a question, although you won't be asked these questions, but online they will be. Have a co-occurring psychiatric condition. If you have a co-occurring psychiatric condition, you're more likely to follow through. Now, I think we'd all be tempted, well, let me just designate you as, what would you like? Would you like a little personality disorder here? It'll increase your chances of following through. We can't do that, but it is a predictor. Now, Kaiser Permanente, you've heard of them? They are the big managed care organization on the West Coast. And they do lots of studies. And so they did a study. They want to know what are predictors of a good outcome on people who complete chemical dependence treatment. And there were three. There were three predictors, really strong predictors, at least the first one. And the number one correlation, the first correlate, is those who engage in 12-step or some other similar support group. That really predicted good outcomes. The second was what we alluded to before. It was that if they had a mental health condition co-occurring and saw someone for it, so co-occurring mental health condition. And the third was if they saw a private medical doctor for a non-urgent problem. Non-urgent. In other words, you don't go in there because you've relapsed and you're in withdrawal again. Hi, doc, I'm out of treatment. Those are predictors. And years ago, long before I worked at Brighton Hospital, Brighton did their own study and looked at what was a predictor for who succeeded when they left. And in our study, or their study at the time, the number one predictor was individuals who went to a 12-step meeting the same day they got out. The same day they got out of treatment. Now, granted, that may be a little, I mean, maybe people who went are more motivated to begin with. So I know it's not 100% science and data driven, but still I found that very interesting. So these are strategies to promote the initiation of treatment after detox. They are in your handouts, and I think that I don't think it's necessary to reiterate any of these. They're for individuals like yourself, probably second nature, but these are there, the little tools that, for instance, call to reschedule missed appointments. I assume most of you are therapists. You may or may not do that yourself, but you might engage someone in the office to do that. So with that, we have Module 4, and as promised, a break. 10 to 12 minutes, coffee break, and we'll resume at about 10 minutes to 11. Except for the fact I'm a little bit hoarse, so I apologize for that. Out of interest, Ruth had asked how many of you here, I went around the room and got where you work, but how many actually work in a detox setting? A few, okay, so not too many. Okay, so maybe, hopefully this is helpful. You see what happens before you get the patient? Or what doesn't happen? And the other thing that we're going to talk about a little bit here is that, you know, the risk of people leaving against medical advice and how frequent that occurs. And, you know, don't take it personally. There is no way that any treatment facility under the sun is not going to have AMAs against medical advice. You know, can we improve? Do we do all we can? What areas might we be able to improve upon? I like the idea when they put a multitude of factors rather than saying, well, what you're doing wrong is, you know, I still don't respond too well to that from my old using days. But I like that they put a multitude of factors up there because you can look at those and go, oh man, we got this hammered down. We really do a good job with, we might be able to beef this up a little bit. I find that, you know, non-threatening and yet hopefully helpful.